tasked to discuss the Newton knee arthroplasty, especially in the ASC setting. And so we're going to go through a few things here. So here's my training, here's my disclosures. And so we'll just kind of keep moving forward. Why do I use it? I'm an old timer when it comes to navigation. I've actually been navigating total knees since 2003 when the early systems came out. I started with the DePuy size system, which was certainly one of the first. At the time, it was mainly static technology. We measured our points, we made our cuts, and we sort of went with it. But I believe in the technology. I've been using it fairly consistently, not the size system anymore, but different systems since 2003. What's different about the Newton system, it allows dynamic data. It allows for a kinematic knee, and it's as precise as anything on the market. Exactech's done a very good job of getting it out to the market with minimal need from them in terms of what do we need? We just need some trackers. We need a unit that's about the size of a laptop that we attach to a rolling pole, and then we need the rep. The rep's a key component of this. The main thing for them is they have to know the software, patient selection. Easy knees can be done anyway. They can be done even with conventional instrumentation. I think it's the difficult knees where technology really has a role. My setup is a standard total knee setup. I use a bump under the hip. I use a lateral post. I use a little bit of a flexion bump. I personally put the Newton on the opposite side. I do not attach it to the bed. It sees for about 135 degrees. And so I find if you put it on a free rolling pole with a sterile cover, it's hardly ever loses the trackers. There's two workflows. There's a femur first, which uses good old-fashioned ligamentaxis, and then there's a tibia first, which was the original Newton in the sense that you have to use the Newton device, which you see below. What I would say is just do what feels comfortable. The exposure is the same for a typical total knee. Medial parapatellar approach. I do shade my skin incision just a little bit medial so that the femoral tracker doesn't really push on the skin the whole case. The femoral tracker goes 1 centimeter above and anterior to the medial epicondyle. The main thing is you have to just get a look. You don't want your trial to hit it because you're still gathering data with the trials in place. And so you definitely want it to be below the plane of the anterior cut. As you start, the tibial incision needs to be just a little bit longer because that tracker is just a little bit lower. As we've done a few cases, I've been able to elevate my incision some. And so what I do is I hook a tibial stylus to the tracker. I set it at 0 and I sit it on the edge of the tibia. And then that'll give you enough excursion in your cutting guide within that incision. My workflow is pretty time neutral. I think the studies show it's less than 3 seconds per acquisition point. And so especially if you navigate knees now, going to this sort of technology, it's pretty easy. It's a pretty easy transition. And so essentially I get my exposure, I put my trackers on, I accumulate my data points, such as painting the femur, which you see on the right side. I get all my static points. We then attach the tibial tracker, get our tibial points, and then here's where the Newton GPS comes in. We get our dynamic points at 0. Again, with ligamentaxis, we get our dynamic points at 90 degrees. And this sets the kinematic knee. And so at this point in time, we attach our femoral cutting guide, and I'll show some slides. It's a pretty ABC, turns green, we make our cut, and there's a verification process, which is a little bit different than most systems. We hook a flat plate onto our tracker, and it tells us exactly what we cut. We then navigate the anterior posterior chamfer cuts, and this also is different than the older systems in which we still use the mechanical posterior condyles. When it turns green, we pin it and cut, and then we verify the tibia, apply our cutting guide, and then make the cut as well. At this point in time, you attach the trials. I float the tibia, so I do not pin the tibia. I slide it in with the poly in place, and I let it find its way in terms of rotation. And even sort of AP medial lateral where it's going to sit on the tibia, and that's where I pin it. At this point in time, the data gets checked at 0 and 90 degrees. And the main thing here is you're looking mechanically at patellar tracking, you're looking at flexion extension, that sort of stuff, but it also gives you real-time hard numbers on your gaps at 0 and 90. Pull the trials out, clean the back of the knee, do the patella if that's what you do. It's certainly what I do. And then you switch for the real implants. This is just a slide of a typical knee. kind of a old man varus knee. So 5 degrees varus, 10 degrees flexion. So this is a static picture. And here are the flexion extension dynamic pictures. And so the one on the left, what we would do, the trackers would be in place. We've already acquired our static data. We pull it out to full extension, a little ligamentaxis, and it gives us our gaps. We then do the same thing at 90 or close to 90. One of the key points here, if you're going to do a big release, and for instance, in a varus knee, you're going to do a big medial release, maybe you're a PCL taker. It's good to do that beforehand because that certainly will affect your gaps, rollback, etc. And so you don't want to stretch the ligaments that you're going to remove anyway. Once you get the data, then you go ahead and you pin your blocks. You get an A, B, C. You just rotate the screwdriver in that direction until it turns green. And there's a picture, even though it's the tibia, green means go. We make our cut, we verify it, and then just keep moving forward. After the data acquisition, both the standard and the dynamic data, prior to pinning our blocks, usually we get sort of this data slide. And this is really setting the placement of the knee and the components. And so, for instance, on this particular knee, if you look all the way to the left, you see an extension gap of 8 and 7, flexion gap of 7 and 6. Well, with a 9mm poly, that may be a little bit too tight. But then you look at the tibial cut, and it's 2 and 2. So here's where you can make up a little difference. I probably would drop this to 4 and 4, but it's certainly fun to see. If you take femoral rotation, externally rotate a little bit, you see what happens to the posterior medial gap, posterior lateral gap, do a little bit of flexion extension, maybe so-called notch the femur by 1mm, and just to see what happens to the gaps. The benefits to me in terms of the Newton GPS in the ASC is that it's the same exact surgery that's done at the hospital. I don't have to change what I do. If I do a total knee at the hospital, I use the Newton system. If I do a total knee at the ASC, I use the Newton system. Same technology, same workflow. It's a very small footprint. It's the size of a laptop. The cost is about perfect. It's zero. It certainly allows for flipping rooms. It's really just picking up the unit and moving it over, as opposed to pushing the, I don't know, maybe the Mako dishwasher from room to room. Very few disposables. There's no extra preoperative studies that either the patient has to pay for. We have to interpret, we have to upload. It's definitely surgeon controlled. They have active trackers. Again, I can make a cut. I can check it if I don't believe it. I can I can recut. And it's very precise. In the knee, it's down to about 0.5 millimeters. There definitely are some challenges. In the ASC that I use, we don't have a steroid, and that's the way to clean the trackers. And so we actually send them to a sister facility. They sterilize them, and we double bag them and send them back. In the future, there'll be some autoclavable trackers. The learning curve is definitely there on the surgeon side, depending on how familiar you are with navigation, but also the back table. If you want your knee to run smoothly, certainly the staff in the OR have to be trained, and that's where the rep comes in. And as with most of these technologies, they don't really cross implants, and so it's implant specific. It's the same footprint, regardless of the procedure you're doing. And upright, you can see the striker system. It's the tower plus the unit, as well as the sort of non-free floating arm that has to be bagged. And then the Exactech GPS unit, which is down below. In terms of ASC total knee replacements, what are some of the challenges? I personally think the biggest challenge is buy-in. You have to get your so-called home team. And what I mean by that is you got to get your office to buy in. When people call in, they have to answer the phone correctly. You have to get your MA on board. You have to get your scheduler on board. Everyone has to believe that this is going to be an outpatient procedure, because in that sense, that gets the patient on board. I think the other key component is the ASC team. Not only anesthesia, that's pretty easy. They pretty much will kind of take it and run with it, but it's the pre-op nurses, it's the post-op nurses. You don't want a pre-op nurse saying, oh, you're going home. And so you really have to get everybody on board. Contracts are less of an issue, but these implants are usually more expensive than a lot of the things that have been doing in the surgery center. So you just want to make sure you're not upside down. One of the big things I see, I work at an ASC that was built several years ago, is we don't have the capacity to turn over instruments. Total joints have pans. They're not open and disposables. And so You have to really make sure that you plan properly so that the instrument turnover can happen efficiently. Technology in general is expensive. The Newton GPS can help offset some of that. But if you're going to do navigated surgery, robotic surgery in the ASC, it's expensive. How do we overcome these obstacles? I think in the ASC, consistency and communication are the key. You have to get everyone's input. Again, whether you want to grab somebody from your office, grab a pre-op nurse, grab a PACU nurse, grab the anesthesiologist, you want to form a team. You want to go through what could we do better, what could we do worse, and I would say debrief about every 3 to 5 cases. And then again, from the operation side of the ASC, the Newton GPS can really streamline the process. Perioperative pain management is key for total knees in the ASC. In my mind, some of the key takeaways for success: patient selection. Obviously, as you get started in the ASC, we all want the 55-year-old skinny patient. Unfortunately, they're very few and far between, but patient selection. I do think in-house PT is well worth the money. Our PT, I think they bill the patients maybe if they can, but if not, we pay them anyway. Accessibility to the staff. Again, communication and consistency. It really takes away the patient apprehension and makes it a better experience than getting woken up at night as an inpatient in a hospital. In terms of the Newton GPS compared to the conventional robot, a couple of key points. It's time neutral. I think the learning curve in the knee is probably somewhere less than 10 cases. Very cost effective. Not only the cost of the unit, I know with some of the robotic systems, they embed the cost of the unit in addition to sort of the initial down payment into the cost of the implants. And if you don't hit the threshold, then you get a bill for the rest on a monthly basis. There's definitely no software maintenance cost, which can run up to $75,000 a year for the robots. It's a really small mobile footprint. It's as precise as everything on the market. Very few disposables, which not only is a cost savings, but even just a space savings in the ASC where space is a premium. And the trackers, they're active trackers. In other words, they're constantly refreshing, they're constantly updating. And so it's a two-way data in, data out. And so you get real-time data in doing all these things. Thank you, guys.